Good morning, everyone. Dr. Rakhi Dcruz, and I'll be presenting my study on optimizing conjunctivitis treatment, a study on preferred practice patterns in South India. So, conjunctivitis, commonly referred as by pink eye, represents one of the most prevalent ocular surface disorders globally. But the management of conjunctivitis varies substantially depending upon the perceived etiology, the clinical training of the ophthalmologist, as well as the regional healthcare practices. So, in many parts of South India, where the patient volume is high and access to culture and sensitivity is limited, ophthalmologists often rely on empirical management strategies. So, the primary objective of this study was to evaluate the effectiveness of these empirical management patterns across South India. And secondary objective is to examine the necessity of culture and sensitivity testing and compare the prescribing behavior of general ophthalmologist versus cornea specialist. So this was a cross-sectional study which was a questionnaire-based Google form study done over a 2-month period during the peak conjunctivitis season. This form was disseminated electronically via WhatsApp, institutional forums, and via email to consultant ophthalmologists across 3 Indian states, Kerala, Tamil Nadu, and Telangana. The questionnaire actually had questions related to diagnostic strategies, how they differentiate virus and bacteria, preferred first-line treatments, clinical decision-making regarding the use of culture and sensitivity, follow-up of the practices, and duration of therapy. Also, the influence of institutional guidelines versus a personal clinical judgment on the prescribing behavior. This form was pre-validated by a panel of 3 senior ophthalmologists. So we analyzed total of 77 completely valid responses from experienced ophthalmologists in South India, of which 47 were comprehensive ophthalmologists and remaining 30 were cornea specialists. Viral conjunctivitis was, of course, the most common encountered type. Diagnosis was primarily clinical with microbiological testing rarely utilized. Supportive care and lubrication was universally advised. Virus was nearly 80%. 80% of all the routine cases were prescribed empirical broad spectrum antibiotics. The most common one was fluoroquinolone, moxifloxacin, followed by aminoglycosides, macrolides, and chloramphenicol. And surprisingly, nearly 47% of the people gave a combination of an antibiotic with a low dose steroid as the first drug during conjunctivitis. So and now let's see how when they started to give. 40% of them initiated even before the appearance of SPK. Just on seeing conjunctivitis itself, they have started on the low dose steroid with antibiotic combination. 36% started after the appearance of diffuse SPK, and 24% of them delayed the initiation until the SPKs progressed to subepithelial lesions, causing visual disturbances. The steroid use was varied in timing and dosage, reflecting that there is a lack of standardized treatment guidelines. Preferred low-dose steroid was loteprednol and fluorometholone. Prednisolone acetate was preferred in high potency in severe cases, hemorrhagic conjunctivitis, pseudomembranous conjunctivitis, diffuse SPKs, or anterior uveitis. Preferred drug in confluent pseudomembranous cases was Predford. Most common frequency given was 6 times, and clearing was noted nearly in a 10-day period according to the consultants. In the cases with confluent SPK with vision drop, majority preferred loteprednol, but all the cornea specialists uniformly gave prednisolone. Systemic steroids was reported by 32% of the consultant, primarily in refractory cases. IV dexamethasone was practiced as a stat dose, followed by a 1 week of oral steroids by nearly 15 consultants. Antiviral ointments were used only by 30%. This was used on the appearance of SPKs. Acyclovir 5 times daily was preferred, followed by ganciclovir. Treatment was discontinued after approximately 1 month without any tapering. Majority believe that antivirals does not have any significant benefit. So the tendency of the ophthalmologist in this study to prescribe empirical broad spectrum antibiotic combined with a low dose steroid in viral cases contrast markedly with the evidence-based common recommendation, which caution against the antibiotic use due to the self-limiting nature of viral conjunctivitis and the concern about the rising antimicrobial resistance. Topical corticosteroids remain the important therapeutic tool in managing the inflammatory sequelae like viral conjunctivitis such as in SPK and pseudomembranous conjunctivitis, as stated by other studies also and as stated in our study also. The judicial use of low-dose steroids reduced the discomfort and visual morbidity associated with subepithelial infiltrate, but it actually needs a careful exclusion of herpes simplex virus, because in cases of herpes simplex it can lead to exacerbation. This is not being followed by many. And high dose steroids were correctly limited to severe cases in our study also, consistent with recommendation by others, but always there is a risk of prolonged viral shedding with high dose steroids. Despite the therapeutic benefit of antivirals, acyclovir ointment was given only by very few people, and acyclovir ointment still remains as the first preferred agent when herpetic etiology is suspected, as stated by Asari and Barney and Solano et al. Emerging treatment with a topical providone iodine formulation show a promising result in adenoviral conjunctivitis, but it is yet to be widely adopted. So my findings corroborate with the similar observation in international studies of conjunctivitis pattern, where overuse of antibiotic and steroids is driven basically by the diagnostic ambiguity and the clinical preferences. This current study states that there is a gap between the ideal and actual management, emphasizing that there is a need for a regional tailored protocols and enhanced diagnostic support with a simple testing like a rapid adenoviral testing for and ongoing provider education. So to conclude, the preferred protocol pattern from this study was use of lubricating eye drops in all cases and to introduce low-dose topical steroids only if complications developed. In all cases with severe pseudomembranes, hemorrhagic and conference SPKs, prednisolone acetate is to be preferred. Systemic steroids may have an advantage in severe non-resolving and prolonged cases, but current evidence is still limited and further studies are needed before incorporating them into a standard protocol. High rate of SPK seen in this study may be due to the inconsistent management patterns over use of steroids, emphasizing the need for a formulation of a unified context-specific treatment guideline. Thank you.
So, Dr. Rakhi, this is a good study. The only thing is you have sent questionnaires across South India, you said.
Yes.
You said you had cornea consultants, you had general practitioners also. So, you know who gave steroids or who gave antivirals. You have that data. You didn't divide that as the responses
I have
from
47 were from comprehensive ophthalmologist,
Yeah.
30 were from cornea specialist. Just mentioned.
So that's there, but in the results you have not said separately on who gave steroids or who gave antivirals as initial
I
treatment.
had actually mentioned, ma'am, all the institutions are mainly sent to the cornea specialist, ma'am. So they preferred, most of them preferred mainly lubricants initial visit, and then they started low-dose steroids solely later. And very few had given high-potent steroids, and that too in refractory cases only. So that is my conclusion towards the end of the study.
So
to
what is the
follow that.
take-home message now?
That is the take-home message, ma'am. Better to give, first try to differentiate the etiology. If you are very sure that it's bacterial, you can start the antibiotic. Otherwise, don't start it in the first go. Also, don't start an antibiotic with a low-dose steroid as the first drug. Start with the lubricant, follow up very frequently, and if you see that it is worsening, you can actually start a low-dose steroid. And in refractory cases only, you go for this high-potent steroids like prednisolone acetate.
Thank
Where did the practitioners consider other etiologies like microsporidium and other things?
Yeah.
Had they considered?
Yes, sir.
Okay.
Few of them had considered about others.
Other etiologies as well, and also the timing of the presentation is important, especially with antivirals. So because it's most effective only in the first 48 hours of active multiplication. So it would have been interesting to know if the practitioners had considered that factor before starting antivirals. Supposing the patient had come after 3 or 5 days, possibly the antivirals would not have been effective. Maybe.
Yeah, according to the, there was a question, when are you planning to start? When did you start antivirals? What time period? And most of them said after the appearance of SPK.
I think one of the most important thing is the parental counseling, because the viral cases will have a period of exacerbation and then only it will remission. So initially the parents will be very apprehensive. When they come, it will be very mild, especially if they come in the first or second day. Then there will be lid edema and there will be worsening symptom and then it will reduce. I think that pressure in the private is to keep them happy. So that may influence the line of management. But counseling is very important, I would say.